Okay. The third one, Dr. SUNITA, who is going to present on the comparative evaluation of longitudinal ultrasound pulse, burst, OSIL, and OSIL LP mode of phacoemulsification.
So good morning to the chair and the audience. My topic of presentation is a comparative evaluation of longitudinal ultrasound pulse and burst mode with the OSIL and the OSIL IP, that is the intelligent phaco modes of phacoemulsification. So now one would think why this study is being conducted. It is being conducted because not all the machines have the OSIL and the OSIL IP or the elliptical modes of phacoemulsification. But the burden of cataract, as we know, is a huge burden. So not every machine has that modulation, so we need to know what is best for the machine, for us, that is available in the machines. So the study was conducted to compare the efficacy of traditional longitudinal with the torsional modes of phacoemulsification in terms of cumulative dissipated energy, ultrasound time, effective fluid used, endothelial cell count post-operatively, and the best corrected visual acuity. It was a hospital-based randomized controlled prospective study with a total of 240 cases divided into 4 study groups. Pre-operatively, best corrected visual acuity and grade 4 dense nuclear cataracts according to the LOX3 grading system were included, and the endothelial cell count was done by specular microscopy. Infinity vision system was used with the uniform settings of 0.9 mm 30-degree bevel, 20-degree bent Kalman macro tip with a vacuum of 350 to 450 mm Hg and aspiration fluid rate of 45 cc per minute. The irrigation bottle height was 110 centimeter. The power settings used in different groups were, for group A, that was the longitudinal pulse mode, was 60% power with a 50% duty cycle of 6 milliseconds on and 6 milliseconds off, with a total of 83 pulses per second. Group B was longitudinal burst mode with 60% power and a burst width of 35 milliseconds with subsequent off time to 0. Now, Group C was continuous OSIL with 100% amplitude linear torsional power, and Group D was intelligent phaco OSIL with 100% amplitude torsional power with a 10 millisecond longitudinal pulse when 95% vacuum is reached, and the ratio of longitudinal to torsional was 1:1. Intraoperatively, the incision was of 2.8 mm standard incision with a quick chop method technique was used for phacoemulsification of the cataract, and the cataract grade was confirmed at the time of chopping the nucleus into 2 halves rather than simply relying on the visual estimation pre-operatively. The parameters recorded intraoperatively from the matrix were cumulative dissipated energy, ultrasound time, effective fluid used, and post-operatively parameters recorded on day 1, day 3, day 7, and day 30 were endothelial cell count and best corrected visual acuity. So the results were the mean CD, the ultrasound time was least in the longitudinal burst mode compared to all the other modes and was highest in the continuous OSIL mode. The effective fluid used was least in the longitudinal pulse mode compared to all the other modes. So this is a bar diagram for the same, and post-operatively, there was no significant change in the endothelial cell count and BCV in all the 4 groups. So to conclude, the burst mode is the most efficient ultrasound phacoemulsification in terms of CD and ultrasound time, as CD, ultrasound time, and EFU are the most direct measures of its efficacy. Burst modality is used only when required, whereas in longitudinal pulse and continuous torsion with or without IP, there is significant measurable wastage of the initial energy, or there's loss of energy as it is repeatedly or continuously being used even when it is not required. In torsional phaco, though, the energy dissipated is only 4.4 in comparison to the longitudinal ultrasound. However, it has to be used in the continuous mode and with high power settings of 80 to 100%, whereas in longitudinal mode, the power used is only 50 to 60%, thereby explaining the difference in the CD and the ultrasound time in the results. So though intraoperatively CD and ultrasound is significantly lower in the burst mode compared to other modes, however, it does not affect the postoperative visual recovery, thereby emphasizing the relevance of the technique in phacoemulsification. Thus, it is the surgeon and the technique which ultimately influence the final outcome of phaco in surgery rather than anything else. Thank you.
Good, very nice. One thing I would like to tell you, you are a postgraduate, is it not?
No,
are you a postgraduate student?
Senior
No.
resident.
Huh?
Senior resident.
Okay, so one thing is don't crowd your slides like
Slides,
this,
yeah.
and don't type in all capital letters, and it makes everything looks the same. You know, so highlight points and then so that it's a 4-minute presentation. So you have to get the maximum out of your slides. That is, the slides are marked here. So, and then I have presented a similar paper around 20 years back, or maybe 15 years back or something.
Okay, sir.
But then, with your endothelial cell count, how long did you follow up endothelial cell count?
So 30 days. 30 days.
30 days is very low to compare endothelial cell, but that's okay. But if the endothelial cell count is not bad, then this CD actually does not correlate anything to clinical stuff. But then good that you have used less energy in this one. So if properly used, energy little more doesn't matter actually. But well done.
So it might not matter in a healthy cornea, but it may affect the poor endothelial count cells. Like,
Come again.
so it
No,
might
speak
not
to the
have-
mic, speak to
sorry.
the mic.
So it might not have mattered in these cases because they were all healthy corneas with the normal endothelial cell count pre-operatively. But for cases wherein we have poor endothelial cell count or there's poor corneal health, these modulations might give us some better results.
Yeah, definitely. When CD is less, it's better.
Yes.
Good.
Thank you so much.